Welcome to 52 Questions. I'm Shannon Weber, Director of HIVE. Every year, HIVE answers hundreds of questions from patients, their partners, and providers. And each week in 2018, we're bringing one of those frequently asked questions to you in video format. And for this week's question, we have Dr. Deb Cohan, and we're actually doing this question a little bit differently than other questions. And that's necessarily a frequently asked question, but something that I've noticed that's happening in HIVE Case Conference. And HIVE Case Conference is the weekly discussion we have about all the patients that were being seen in clinic. One thing I've noticed in case conferences, there's a lot more conversation right now about antiretroviral use during pregnancy. And I'm wondering if you could talk about what are those things that we're talking about and what are some of the considerations that people might have right now.
Yeah, there are two main issues that are going on right now. One is around safety, and the other is around basically the levels of drug in the bloodstream and whether certain of the antiretrovirals, the levels stay adequate during pregnancy. So in terms of safety, the big thing that's happened this year is a question about whether dolutegravir is safe during pregnancy, and in particular in the very, very early part of pregnancy when most women don't even know if they're pregnant. And this all came about because there were 4 cases of what are called neural tube defects, where the spine does not form correctly. There were 4 cases identified over the course of 6 months in Botswana among women who were on a dolutegravir-containing regimen starting at the time of conception, so very early in pregnancy. And that was much higher than what one would expect just in the population. So really concerning, and really important to understand that these are only 4 cases, and this is in a specific part of the world. And we know certainly all sorts of environmental exposures, et cetera, can be associated with birth defects. So that said, this certainly has gotten a lot of attention. And the way that I have used this information and when I'm interacting with my patients is I describe what we know, and importantly, I describe what we don't know. And I also explain that certainly there are plenty of women for whom them being on dolutegravir during pregnancy has seemed fine. And really the bottom line is I leave it up to the woman. I try to really inform her as much as possible, but I really want her to make the decision. This is not for me to make the decision in case conference before I even see her. My role is to explain to her there are these 4 cases. It's a higher than what we would have expected, and let her make the decision. And what I've noticed is it's not always predictable. Some women are really risk averse, and they said, I don't want to take anything that potentially is going to risk anything for my baby. And there are other women who said, you know what, I've been on this dolutegravir containing regimen for however long it's been. I've had an undetectable viral load. I have no side effects. It's 1 pill once a day. And this is working for me, and I am afraid to switch, or I don't want to switch. And my role really is just to give women information and then to ultimately respect whatever choice they make for themselves.
And for the dolutegravir-containing regimens, the concern is really during that early period when the neural tube is forming. So is it after a certain number of weeks that it's not that same concern, or is it something you're worried about the whole time?
Yeah, thank you for asking that. The different guidelines have landed on a different gestational age at which it's safe, beyond which at which it's safe to be on a dolutegravir-containing regimen. The bottom line is that the neural tube forms at about 6 weeks or so. What I think everyone agrees is that it's safe starting in the 2nd trimester. Some people call that 12 weeks. Other people call that 14 weeks.
Okay.
But kind of big picture is we think 2nd and 3rd trimester definitely is safe. And in fact, the US guidelines now consider it a preferred regimen for later in pregnancy. It's this very early pregnancy where it's a question.
Got it.
So that's one issue around safety. And the other piece is we have a lot of information about all the different antiretrovirals through the Antiretroviral Pregnancy Registry, and nothing has come out of that way of evaluating safety that is of concern for any of the antiretrovirals, including dolutegravir. So that's safety. And then another issue that's come up is around what we call pharmacokinetics. And that basically is, someone takes a pill, how much of that medicine it can be found floating in the bloodstream. And because of the way that pregnancy changes the body, among other things, it also changes how the body basically chews through certain medications. And there are medications that contain cobicistat. This is kind of a newer regimens. Some contain cobicistat, and the concern is that levels appear quite low of the cobicistat containing antiretroviral combinations in pregnancy. And so that includes Genvoya and Stribild, for instance. Those levels appear to be lower during pregnancy.
Is that impacting women's viral load, or what does it ultimately mean?
Yeah, I mean, basically, the studies, typically pharmacokinetic studies are small. So it's hard to show that it has an impact on viral load and certainly on HIV transmission. But the levels are low enough. In some cases there were, 40 to 50% lower than we'd expect outside of pregnancy, that there's real concern that the levels really aren't high enough. And you can't just take two, because then the other meds that are in those co-formulations, it would be too high of a dose. So the current recommendation is for someone who is not yet on meds to avoid these meds, to not start these meds in pregnancy. If someone's already on the medications, to get into a conversation about whether they would prefer to switch to something where we know the levels, both it's safe and the levels are adequate, or to stay on the same regimen but do more monitoring of the viral load and also potentially therapeutic drug monitoring. And again, this is one of these situations where I think it's so important for us to not take the decision away from women and for us to say, this is what I think is best, but in fact, present the information to the woman and really help her make an informed, free choice. And I, again, have been surprised. Some women have been really risk averse and said, please take me off of this regimen. In fact, I have two patients who are pregnant on Genvoya, and one said, oh, please take me off it right away, switch me to something else. And then another patient just today said, you know what, this has been working for me for the past few years, and I am tolerating it really well, and it's one pill, it's super easy, I do not want to switch. And I'm like, okay, then we won't switch you.
Yeah. Awesome. Thank you for sharing. All right. Thanks for joining us, and have a good week.
Bye.